perhaps lagging behind some of the emphasis that we were otherwise focusing in on with very important areas like healthcare-associated conditions. The National Action Plan itself focuses on the 4 foundational areas you see on the screen. In our original edition of this series, we talked about the plan very broadly. And for those of you that are first timers, I encourage you to check that out. Our second series focused on the important work associated with culture, leadership, and governance. And our last one was focused on patient and family caregiver engagement. And they all have wonderful, suggestions for you to consider. Today, we're focusing in on workforce safety and well-being. And the next in our series, as you'll hear at the end, is focused on the learning system itself. Within the within the workforce safety and well-being domains are actually 3 high-level recommendations that center around the following areas, including implementing a systems approach to safety, assuming accountability for safety of both the physical and non-physical and psychological nature, and a healthy work environment that fosters the joy of the healthcare workforce, which many of you said was an area that remains to be much more mature in your organization, and developing, resourcing, and executing on priority programs that equitably foster workforce safety and well-being. Now, the first question that we asked you about was your familiarity and use of the Safer Together assessment tool. And by the way, the National Action Plan and the assessment tool and a user guide for the assessment tool and an implementation resource guide are freely available on the IHI website at the links that we have embedded in the slides, and you'll get copies of this information. But what you see on the slide in front of us here today at the bottom are those 7 elements that are part of the workforce safety and well-being foundational area. And we are showing one of those elements around goals and strategy for workforce safety and well-being on the screen. And what we invite and encourage you to do and have talked about in the first of this learning series sessions was engaging an assessment team in your organization, whether you're a hospital or primary care office or any care setting, to come together and evaluate where you think you stand across the 4 areas and for each of the elements. And you can see that if you're unsure, there is a selection that you can make on that front. And you can see increasing levels of maturity, saying maybe we're just really at the beginning when it comes to goals and strategies around workforce safety, or at higher score levels, you'll see that sophistication and the work around goals and strategy is much more established. And this is a really beautiful guidepost for you to use to get a sense of what the lay of the land might be and where the opportunities are for improvement. And you will also see, and this is a total eye chart, so maybe my use of that word, you will see, is not quite appropriate in this case, but this is just to let you know that as we think about safety, again, as a real-time property, as work that is constantly needing to happen, that there is always something that organizations can consider as part of their improvement plans, no matter what their level of maturity is. Whether your organization is at the very early stage or whether your organization is making significant or exemplary impact, there are still opportunities for improvement. You're going to see how some of this comes to life in Karen's conversation today. Now, one of the other questions we asked was what your familiarity might be with the CMS Patient Safety Structural Measure. This is a measure that went into effect in this calendar year for the first year of reporting, which ends in December. And this is a measure that is applicable to most acute care hospitals within the United States. Hospitals that fall under the reporting obligations of the Patient Safety Structural Measure will submit their self-attestation of their scores in the spring of next year. And then a year from now, those scores will be publicly reported on the CMS Compare website, and hospitals that are obligated to report and choose not to will begin to face reductions in their CMS, or excuse me, their Medicare reimbursement. So this is something that we know many of you, particularly if you're in the US, are focused on very heavily right now. And what I wanted to lift up was just a little bit of a crosswalk of some of the elements of the patient safety structural measure that address workforce safety and well-being. You'll see there are 5 domains of the measure on the left-hand side, and I should say that the patient safety structural measure was heavily informed by the Safer Together National Action Plan. So there's nice alignment between the two. Under Domain 1 and leadership commitment, there is emphasis on reporting not only patient safety events, but workforce safety events and initiatives. And where there are more explicit and more direct alignment with our focus area of workforce safety and well-being today are in the areas of strategic planning and organizational policy, asking whether hospitals focus on a fair and just culture and have action plans in place with improvement activities and measures for things like physical harm events, slips, trips, falls, and needle sticks, but also for psychological safety. And of course, violence is a part of this as well. In the third domain, the culture of safety and learning health system, it addresses whether hospitals conduct annual culture of safety surveys using a validated tool and are using the results for improvement. You're going to hear about that in Karen's conversations today. And the fourth area where there's a special relevance is under accountability and transparency, particularly with communication and resolution programs in the aftermath of harm and addressing care for the caregiver. So with that very quick backdrop, it's time for me now to turn things over to the real again, star of the show here today, Karen Garvey, to share more about what she and her Parkland colleagues have been doing to evolve their comprehensive workforce safety program. Thank you.
Great. Thank you so much, Patricia, and thank you for allowing me to be here. Just doing a sound check to make sure that I can be audible. Great. Thank you.
You are great.
All righty. So, we've been on this journey. I've been at Parkland for 11 years, and, my prior organization, we also did the same and did some work in this space. But being a patient safety professional, a risk management professional, and also being a nurse, it kind of made sense to kind of really zero in on some of the things that were being identified within Parkland. If you're not aware of Parkland, Parkland is a safety net standalone facility with multiple clinics in the outlying Dallas County area. And it has been cited in Becker's for the last several years as being the busiest emergency department in the nation. We are one facility and taking in about 240 to 250,000 patients a year. So it's very busy. But coming here and seeing some of the work that's being done and some of what they face every day, it became apparent very early on as I was invited into the emergency department and saw myself and witnessed myself some of the activities or behaviors that they were subject to that really pulled together at that point in time a emergency room physician, the head of behavioral health, and myself to start a plan for how we were going to charter a committee and stand this up. And frankly, an untoward event that had happened in the ED at that point in time, that became the linchpin and the opening of our multidisciplinary committee. So I call it a full court press because it is truly that, and you will see that in the structure. I'm a clinician, but you know what? We need so many other folks to be able to work with us alongside locking arms to move forward. And that's why it becomes something that is so high on people's radar, and we're educating each other in it as well. So I'm hoping I can forward these. Let's see. So headlines that are out there, there's many of them. I can't move this forward. Let's see. But these are all from earlier this year, and there's been some of them. These are all happening in the healthcare setting, and it's it's not something that you may hear on the news. Ironically, we hear about airline industry and some of the snafus that are happening within airplanes and things like that. But very rarely do you see something splashed on the local or national news when it comes to these items. It is it's probably for good for it's very purposeful and intentful, because we probably don't want people to think that hospitals or where we work are unsafe places. But having been a nurse for several years working in the space, we realize that workplace violence has been there for a long time. It really emerged as a almost an epidemic during the pandemic, although we knew it had been there for some time. So, saying just having a moment of silence for these individuals who are impacted, as well as their families and their peers, it becomes critical that we take care of these individuals. What we're also finding, even in more recent research that's out there, is that many of these I'm having trouble here. Many of these recent shootings have been related to some long-standing grievances. So 20 years plus, where people are coming back with a vendetta to find the individual that may have pronounced their loved ones. So some of these are not just the immediate, they are also out there with long-standing things, which is, I think, coming more into our scope. And there was a recent article by the Mayo Clinic that actually looked at what we see in society, all the out of hospital violence that we see, the road rage, all of the things that are happening within our communities. If people are known to be violent within their community, almost 42% of them are going to be violent when they are in your hospital. So that's something that I don't know if we are aware of that, if we are taking measures to ensure that just because they're coming in, they may be in a stabler state. In our ED, they're not. But this is even happening beyond the ED and into the inpatient units. 54% of the med-surg areas last year had a higher percentage of workplace violence than in previous years. So because of the coexisting behavioral health and medical conditions where they cannot be cared for in behavioral health units, they're now dispersed in other places, as well as in the obstetrics area. So, this has become basically during COVID, I was sitting on a national board for risk, and I said, is anybody seeing this really escalate, not only in number, but the severity of events that were happening? And so it became something that we were talking about, but became more apparent that this was becoming more of a significant issue that needed to be addressed. Regardless of what data you look at, 3 to 4 nurses are being assaulted per hour, and that's just nurses that they've identified. But we realize that there are so many other healthcare workers that are impacted by this that may not be necessarily visibly seen or written up about, but it is impacting every single one of them. Many states, there's a patchwork of states that have now laws in place. I was fortunate to be able to testify in Austin in 2023 to help push our bill forward. But I had been monitoring that bill over time for several years, and I did a gap analysis in the beginning to identify that we had several gaps that we needed to close, and was naive to realize that the bill dropped during COVID. But we kept muscling forward to close those gaps. And so when it became time to testify, we were identified as the only facility in the state of Texas that had every element of the bill in place prior to signing into law. So that's become, something that we've been really proud of. And, required a workplace violence plan, which you will see, later in this presentation, which was required hospitals were required to be compliant on September 1 of 24, but with their first one, we are moving into our 6th plan. So we are continuing to forge ahead. We're finding that it's not just the clinical areas. We've got to provide safety and security in all places for everyone. It's the physical environment, the physical safety, egress, access points, all of these things that it really need to change the culture. And how do we embed this within what we are doing day to day? And then also when it comes to, other supportive staff, EVS, dietary, some of the respiratory therapy, radiology, these support mechanisms in areas that are so important to us to deliver care, they are also targeted as well. And so this is our Parkland Health mission, vision, and values. Certainly when it comes to advancing wellness, relieving suffering, and developing and educate, that is our mission. We are a community-based organization, and we have also always had the philosophy of being open to the community. And then a couple years ago, we really had to change that philosophy to say, you know what, we're still open to the community, but we really need to keep our employees safe. Our workforce becomes paramount in order to provide that excellent care every day. And if they're constantly in fear of what they're trying to do because of being harmed, they're not going to be able to do that. Our eye care values are there, but I'm also going to focus on our high reliability universal skills. We launched a high reliability program in 2021, 2022. We kind of stopped and started a little bit because of COVID. But I will tell you that this has been a huge, with reporting of safety events, reporting of employee-related events for harm. It's been a wonderful thing because it's not just zero harm to patients as our mantra, it's zero harm to our workforce as well. And that is the goal. So we come at these together. And I think, my own opinion is that, there's been so much emphasis from HCAHPS and patient satisfaction. The way that I equate it is they've always been in the front seat, and we have put our healthcare workers in the back seat of the car. We need to get them to the front seat with the same resources and the same emphasis, so that we're working together as a unified process. So, but it actually has come together to show that we are also focused on the safety of our workforce when it comes to reporting of events, when it comes to looking at the outcomes of serious injuries related to workplace violence. We undertake root causes for those cases as well, just as you would any patient safety event. And I think that may be unique to us, but those also go all the way up to our board of managers for review and feedback. So we do have workplace violence under one of the staff and provider engagement strategic initiatives. And this came out, I think, I want to say like back in 2021. It was identified that violence was really significant in our organization, and how do we combat it? But realizing that our organization had started a committee back in 2015, there was a focus to me to say, okay, what are you doing, Karen, and how can you help to manage this? But in essence, I may be one voice, but there are several voices among the organization that help us move this in. But what I'm proud of is that we do have to provide an update every quarter to our executives, who then take this information to the highest levels of the board to give them an update as to how well we're doing, where are we falling short, where do we need resources, et cetera. And so this is our structure, and it works for us. I think it just kind of gives us, when we do presentations, it gives people the visibility of how high this goes, but also how wide it goes and down. So board of managers, ultimate responsibility in the organization, and then we also have a quality board of managers. This information was just presented to them a couple of weeks ago. I do a biannual update, or more often when it's requested, of what are we doing, especially if there's been things that have been happening around the country or around the state or locally where they may have concerns. A few years ago, I dreamed up the Workplace Violence Executive Oversight Committee, because a lot of this was sitting at my level, and I really wanted them to see, hear, and understand some of the encounters of what our staff were dealing with, and also how we were managing the supportive resources for them too. And this has become successful. We do it like quarterly, sometimes twice a year, because they also get updates through the boards and also other meetings. But it has been helpful to increase the transparency down to the front line, all the way up as to what is going on. And I think additionally too, I run our executive huddle, facilitate that every morning. We also had put on our executive huddle board the number of workplace violence events that have occurred in the last 24 hours. And I will tell you, when we started this, it was because there was an individual in our organization that didn't really realize that these things were happening in our organization. So my job was to get it out there and transparent. And we have not had one day without a workplace violence event reported. So these are happening every day. Our quality of care and patient safety committee is something that we bring cases forward as well, and they certainly translate up. But the preserving the environment, a care committee, I will get into a little bit more, and this is where we actually manage the behavior of the patients, all the way from letters to system discharge. And we are a safety net organization, and we have system discharged about 18 patients in almost 3 years. So, but it is our way of managing it. We also work very closely with the folks on the left-hand side, environment care, legal, our Office of Talent Management, where we may place employees who don't feel safe in their role because of what they have to interface with. We will place them in different roles for them to retain them in the organization. General operations, clinical informatics with our alerting mechanism in the medical record. And then also we work closely with our nursing folks, the Magnet program. We did do a great presentation for the Magnet survey that we had in August. And then certainly we work with our physician groups, the Joy at Work, clinician well-being. We have a group that I'm part of as well. And then every area at the bottom, they all have different areas of risk. Our emergency and behavioral health, definitely. Being the busiest ED in the nation, high behavioral health unit, they definitely have their own work group with their own goals. We cover the 7,000 inmates at the jail. We have definitely different types of risks in that space. And we found that our APPs, who do great work for us, they are sprinkled among many service lines and weren't getting enough information. So they have a group together, and they've created an awesome wellness tool on how they can take care of themselves. And then the ambulatory surgery centers, based on some of the shootings that have gone on across the country, and that has our pain clinic in it as well, and trying to really localize some support services there. And then these last two that are in green, the star is not on there, but those are new. The community setting was originally written out of our bill, but they're still on our radar because these folks do great work going into high-risk areas, neighborhoods, homes. So we actually shadowed folks to go out with them. When you have a bus or a van with one entrance and one exit, and it's the same one, and somebody comes disruptive in that environment, what is your way out? Those kind of things we worry about with them, and we're working with them. And then also our frontline staff. We know at our level what work we're doing, but how does this translate down to the front line? So we just actually launched that meeting yesterday. Several people joined us, and there's several people that want to be involved in this. So this is going to help us move this to the front line. But again, this is a structure that we have and the structure that works for us. So when we look at our workplace violence trends, I will say that this is data through June on here, but actually data through the end of August, we are nearly 1,900 events reported. So we continue to see an uptick. We want people to report, but we also, as we changed our event reporting system in November of 23, we were very intentional about where we placed that icon. When you look at all the icons that are out there, we placed it first. Because if you look at many of them, they're in alphabetical order. W would be at the end. They would probably never see it. We would get it in other category or something like that, but we put it first. And so our definitions our event types are physical assault, verbal assault, destruction of property, disruptive behavior, and sexual assault. So in our old system, we were only able to capture one of those. So we continue to see these numbers increase over time. We've already surpassed what we had seen in 2024, but goals going forward are to see a downward decrease because we're able to mitigate those events on the front end. And so we also put together we've identified, as I've mentioned, we were able to capture 5 of these events, or we have 5 events that we actually capture. Old system, we could only capture 1, but if you realize in one episode, potentially all 5 of those could happen. We're now able to capture all of them. So that's why you see a primary, which would be that, maybe it's a physical assault that came in, but yet they were talked about screaming and throwing things. We would also be able to capture those other 2. The downfall of the data of the secondary events is they're collapsed into a 1. So that example that I just gave you of those 2 additional, we would only see 1. So one of our goals this year is to actually expand that out and really blow this up. So we are seeing the numbers continually increase. But again, it's improvement in the data capture. And then when we also look at, we've actually put a rate together. I can move this forward. You know, when we look at workforce numbers. And so when you look at workforce numbers, we take the number of workplace violence events times 200,000 divided by the number of work hours. Again, opportunity to continue to improve on our data, because when you look at work hours, it's going to be folks that are virtual that may never even enter the organization. So we've got to be able to tease some of these things out. But it's really kind of important to see for like the month of June or July and August. July, we saw 200 and I think 16 events. August, we saw 200 events. So almost 20 people out of 100 in some of these months are being assaulted in one way, not necessarily just physical. When you look at the primary and the secondaries together, that's a lot. That is, 20% of your workforce is being assaulted. And that's again for what we know. We still know that there's opportunities to report, and certainly we have a reporting system. We also have a hotline where people can call in and leave information with the patient name and medical record number and a brief description, and we will put it in. Or we also have a pager that they can call us and we will put the information in. So the team has done a lot of really great work to get the data that they need to help us synthesize it a little bit more. And so what do we do when these things happen? We do have a lot of folks that we assemble together are going to our Sparks peer support program and a little bit further down the line. But we do work together as a unit and deploying different resources, spiritual care, employee health, where we have psychology folks on staff, as well as our peer supporters who are trained in psychological first aid. But we work across the health system. And on the upper right-hand side, for victims of violence that have been harmed, we actually put together a workplace violence care package. And the items in the care package actually touch every single sense. So there's lifesavers in there or mints that are in there for taste. There's a soft blanket in there that talks about wrapping you in support, as the card says. Aromatherapy, a lip balm, and then there's also resource packets, and then some of the personal alarms in case they don't have one, although we give them out for every employee on new employee orientation. And then they have the resource packet that's here that actually is organization-wide, what resources are available for you. It may be that you're struggling with something differently than, a different stressor, which may be financial. There's resources on there, and we update that on an annual basis. In addition, we have 2 meditation rooms, one in the correctional health setting, one in the main hospital setting. And we also have deployed lavender carts, which have many of the supplies in the meditation rooms. We deploy them to areas where there may have been a significant unexpected death of a patient, a coworker, something significantly that has happened where we're trying to deal with a lot of interface with a lot of the masses. So, and then certainly the Joy at Work program that we've had with our physicians. I'm part of the clinician well-being group. So, there's a lot of things that people have ideas and we pull them together, and it's a team effort. Everybody gets credit for the work that we do. And so next slide goes into how do we manage the behavior? So we started to work on providing letters to patients. And when the safety event comes in, we take some of that information and put it in there as to, on this certain day, this is how you were reported to have behaved. These are our expectations. This is our code of conduct, and it goes out. And so sometimes they hear it, sometimes they don't. You'll see in the next slide, we've had some pretty good success stories with it, but we escalate that behavior and almost create a file on the individual as to history. And if sometimes they get up to the point where we need to really think about discharging them, it goes to this preserving the environment and care committee, because we want to ensure that the environment is secure where individuals can work. And so we've been able to, we do review cases. We review not only objective information like safety events, medical record, police reports, complaints, and grievances. We also go through their trauma history. Because typically when it comes to trauma-informed care, everybody has experienced trauma. How do we know that we're not triggering them in some way, shape, or form? Broken processes, sometimes administrative harm, trying to go into a place where they don't understand how to navigate can increase frustration. And sometimes that frustration based on how people were raised, they don't know how to channel it in a more positive or professional way. So we've learned in some situations that we've invoked some of those triggers to elicit the behaviors. So we escalate it. We do an advisory for them. Sometimes we may modify their services and actually do virtual clinic visits versus in person. We can send them meds versus allowing them to come on site to our busy pharmacy. Things like that to kind of keep them away or be more deliberate in how we're scheduling them with less people around, and how that's done. And then we go to a committee that is comprised of several devoted people. It's a very nimble committee where it's ethics, it's legal, it's psychiatry, psychology, care management, patient relations, our area. We're all bringing information together to have the group actually walk through the events of the individual, the history of the individual, but also the testimony that's provided by individuals who have been impacted. And so if the deliberation of the committee is that we will terminate them from the system, they have 30 days to find a new provider, and we assist them with that. And then if they are terminated, there's a final letter that their appointments will be canceled, but they can always show back up to the emergency department for emergency care, and we will manage them that way. So should they come back to the emergency department, we have enlisted a process to notify and expedite care through what we call a safety scrum. We manage them very cohesively, intently to navigate them to a place of stabilization and discharge, and or to actually admit them, but also concentrate their care to get them to a stabilized state where they can be discharged as well. And so patients are then monitored. Every patient that has been terminated is monitored up to a year afterwards to validate their behavior, to ensure that termination still continues. Patients can also ask to be reinstated after 1 year. And we've had one person asked to be reinstated, of which we developed an entire workflow for that. We went back to the actual area that actually asked to terminate. They gave us additional testimony, and we denied the reinstatement. We supported the staff, of which that is resounding to them. So we want them to know that we're going to be doing what's right for the staff. So, but in addition, this is the committee that it goes through. And so when we look at what we've been doing, so we've looked at the number of letters that have been written over time, the disruptive behaviors. So this has been a lot of data work for our team, of which there are now two full-time folks who are totally 100% devoted just to this work. I actually got the idea from IHI, sitting on the Workforce Safety and Wellbeing group, that there are people that are actually devoted to this. So we had one individual for 2.5 years, and then we were able to bring on another because of the demonstrated need, which we were grateful for. But when we realize of the letters that go out that provide expectations, we realized that in year one, with 109 letters that were sent, 104 of them did not have another reported event within the next year. Year two, almost double the numbers, 88% same. So this is information that we will likely look. So I equate it to your restraints. It's the least intrusive, but it's making a very positive impact just by sending a letter. So we also send letters to visitors that are disruptive too, because many times visitors who are with patients are also our patients too. So we go to look them up. But I think that this is, again, something that's really positive coming out of this. And there's been a lot of work that's been generated, but it's making a positive impact in the organization. So moving on to Sparks, our peer support program, supporting Parkland staff is something that we are extremely proud of. We're nearing on 7 years of being in existence, and we wanted to realize why we needed Sparks. And when we actually looked at our enterprise risk management survey several years ago, workplace violence was listed on there, has been on there since 2017. And so obviously with different stressors, work-life balance, secondary trauma, all of these things, these conflicts, there's a need for peer support. And so it's a three-tier process. And the peer supporters, of which there are about 60 across the health system, very large, very robust, very dedicated. Their job is to provide psychological first aid, get them to a level of normalization. What did they used to do before this event happened? But we also partner with our spiritual care chaplains, our employee assistance program, our employee health psychologists, people that are available to help us do this again as a team, as a full court press to support our staff. And so we may realize that there are, through the trauma psychologists or the trauma counselors, the secondary level, that they may need additional support. And then if we need to expedite to a professional, we do that as well. We've had instances where people have been in dire distress. We have a process of getting them to a safe environment within our organization where we bring the services to them to get them to a place of stabilization or the next level of what they need. So we've developed that process. And unfortunately, it has been needed. But how we started this, ooh, that's a picture. Back in 2017, we actually petitioned our foundation for some monies. I didn't realize at that time that $37,000 was a lot of money from our foundation, but we actually went to Johns Hopkins, had that team come in and actually do a training for us from their resilience and stressful events, their RISE program. We then had 2 sessions. We took it upon ourselves, and then we created our own. So we do a full day, and we also have role play, theory, all of those kind of things. And this is just continued. This money has been well spent, and it was money that was donated by our staff to create a program for our staff, which is definitely unique. And so we have 2 peer supporters on call 24/7, 365. And Stacy, who's the second from the right, she is our program manager. She is also a chaplain, but she works underneath us in this space. And it has been when people hear that something is going on, Sparks is who they think of. But we also pull in our other colleagues, as I said, with the spiritual care team, because we're all coming in with different areas of experts. In addition, how many folks have we seen over time? We're embarking upon, I think we started February of 2019, and we had 1 year under our belt before COVID. We actually had our 1-year retreat, of which we do a retreat every single year for them, where they don't have to work. It's just how can we take care of them because they're taking care of others. But we have seen almost 7,000 employees in that time frame. We are very busy, and these folks are dedicated. It is a confidential reporting. We don't document any information down, but we do see folks, and we see them on the fly. Even though we have folks that are on call 24/7, 365, I may get a call. I may get a call from an executive saying, "Can you provide support for X, Y, and Z?" But also individuals in the organization know that this is highly confidential, that should they come asking for information about something, they won't receive it because we don't write anything down. We write encounters down as to, if the type of referral, the time it was, the type of thing that they're coming for, but we don't write names down for that. And that's, I think, what helps to maintain the protections. So why are they calling? Before COVID, a lot of it was stress. During COVID, it was COVID. It was things that people were managing when you were homeschooling, people were losing their jobs, fear of COVID itself. But the last couple of years has been related to violence, workplace violence for individuals, but also the trickle-down effect and collateral effect of the teams that are impacted because their peers are now hurt. And as we look now into 2025, it's been stress, burnout, those types of things that we're starting to see. So we monitor, this type of activity as well. And so when we talk about a workplace violence plan, we just met on our 6th year of putting one together. These were our goals for 2025, and we were able to complete 100% of them. We were waiting on the last one at the bottom. When you look on a Likert scale of 1 through 5, and to see what our workplace violence and safety scores were, frankly, year 1 out, I was pleasantly surprised that we had almost a 4. But this year we actually went over 4. So just a little bit over, but it still met the goal. But these are things that we're trying to move within the organization. And when you look at the completion and implementation of an occupational health injury policy, why is that anything that you would put out there? We in our area had created a workplace violence time and attendance credential so we could track folks who are off work for this reason, which was separate and apart from our occupational injury policy. So now we're merging these together. Again, with a time and attendance credential that we could calculate times of losses off of what people are off work. And let's see. And so these were the questions from our vendor that were out there that we actually looked at, and these were the scores from 2024. So again, we were pleasantly surprised to see them actually come up for 2025. And so, Patricia had put up the score for the workforce safety and well-being, and I went in and scored ourselves. I will say that, we're a little lean on job roles and performance reviews when it comes to, adding that information in. But I also know as part of our high reliability journey, where we have now done a lot on just culture, moving, and changing some of the vernaculars of what we're putting into job descriptions, that's on the horizon. And so, I wanted to give us a little bit of credit. We know where this is. There's just some enterprise-wide initiatives that are front and center of where they couldn't get to that right away. But we do have a budget. We were successful in getting a budget this year for not only the violence, but the peer support program, where it's not coming out of our general budget. So we were able to be successful in that, especially because of when you look at the supplies, banners, personal alarms, those are all coming out of our budget. And so little things like that can make a difference. I mean, it may not be big, but at least we have one. That was a success. But these are things, when you look at goals in the organization, there's a lot of emphasis. I mean, the highest level executives are very focused on this, whether it comes to the chief nurse executive, the CEO, the COO, the head of HR, they are all in this together with us, and are certainly calling upon us when things are happening, or when we have new and novel things that are brought our way, to say, hey, why don't we look at, X, Y, and Z as we move forward. So I think that's it. I will turn it back over to Patricia. Thank you.
Wow. Karen, thank you so much. You've covered so much ground, and we could have taken any one of these topics and done a dedicated webinar. And there's no doubt, and we'll invite feedback from our colleagues on what matters most. But thank you for your outstanding contributions. I dropped in the framework for the standardized collection of workplace violence data that you helped us create through your work, Karen, and I would encourage people to do that. Part of the challenges that we've heard over so many years is that if we're not measuring this and we don't have standard frameworks for measuring violence or really any other type of harm, that a lot of this gets lost. And, folks aren't aware that they have a problem, and the data can't be used, as Karen has so beautifully done, to engage all of the executive and governance support for this work. We have a lot of questions. We won't get to all of them. We'll try to pick up a couple of very quick ones right now and see what we can do with Karen to maybe follow up with an email with responses to some that are more suitable for that. But let me just build off of the Sparks questions. There's some comments about, do you have full-time staff dedicated to Sparks? I think you alluded to that. And are these 7,000 support requests or actual support encounters?
So great question. So I have one full-time FTE as the program manager. All of the other 60 folks are 100% volunteer, which shows their commitment to this. When it comes to, what's the second part of that question? Sorry.
The question was whether there's support requests or actual encounters with the requests that have come in.
So every encounter, they're asking for support. So it definitely is. Now that you can have one call, which would create an encounter, but one call which may impact 20 people, we look at the 20 contacts. So, one call, it may be an individual, but it may be 20. So we monitor the number of contacts, which is what you get in the 7,000 number almost, not just the calls.
Thank you. And I'm not going to list necessarily the names of people who submitted these questions in the interest of time, but we have a couple of questions that relate to personal alarms. Can you just share a quick elevator pitch of how they work? And could you also comment a little bit further on the behavior alert and the medical record, and how does it get seen the next time a patient has an encounter with the system?
Great. So personal alarms, I know there's a lot of information out there from tech. We have not gone with tech yet, except for in the community setting. Community settings will go to a local 911, and we're expanding our ability to cover those folks, again, with our foundation that are very gracious. Personal alarms, we have had localized alarms. We teach them, we provide to everyone in new employee orientation. We actually tell people how they work. We make them sound them, put them on their badge. Um, I'm not a proponent of a certain kind, but I will tell you we've been impacted by the tariffs, so we have had to pivot. But I will tell you, sometimes I tell people they're only as good as you have them on you. When you encounter some individual, they're not going to be good on a jacket or in your locker, in your purse, etc. They need to be present and on you. But they have saved people. I will say that because they elicit a local response right away, piercing, and then the cavalry is called through the panic alarms where they're coming in from who knows where in our organization. Because we do have our own police force, but they're deployed elsewhere, and seconds seem like hours when you're waiting for somebody to come. So that's the philosophy that we have had, and to this point, it has worked for us.
Thank you.
Mhm.
And I'm very sensitive to the time constraints that we have here. I think some of the questions have been covered in your general comments. We'll follow up a little bit more. There's a question, Karen, a great one for you. How do we teach the next generation of nurse leaders about some things? And, questions about balancing staff and patient safety, which we know are inextricably linked, and our Lucian Leap work and so much of the work on this front is listed again on a resource slide that Marianne will show momentarily. So with that, I'd like to thank everyone for your engagement. Look for some additional follow-up on this front, including the patient safety structural measure information. There's a request about communication and resolution programs and staff support. So we will get that contact information out to you. And with that, Marianne, I am going to thank you and Karen for our time and turn things over to you for some final nuts and bolts.
Thank you so much, Patricia and Karen. Thank you so much for your time and intense deep dive into the great work that's going on at Parkland Health. We are all the richer for the last hour that we've spent together. I'd like to just very briefly bring us into our last two questions here. If you could please pull out your mobile devices one last time. And we're curious. IHI always wants to hear your voice. What is one thing that you will do differently as a result of our time together? Please provide us that information. We'd like to understand how this is going to impact your practice at your organization. And then last but not least, we've got lesson 5, our learning systems, coming up at our next session in October. We'd love to know what are you most curious about? We have 2 fantastic folks joining us for that session. Dr. Lori Pelletier, who is actually on this call. Lori, we're so thrilled to have you here with us in October. And then Dr. Steve Muthing is also going to be joining us to talk more about the best practices in learning systems. Lastly, Patricia alluded to this. These are core resources for improvement, specifically around all 4 foundational areas of the National Action Plan, but specifically some that will really impact your workforce safety and joy at work. And last but not least, I would be remiss if I did not invite each and every one of you to join us at the IHI Forum in December of this year in Anaheim, California. Come and chase away some of those winter blues. And we will see you October 29th next month at our 5th session for the Patient Safety Learning Series. Thank you so much. Have a wonderful rest of your day.